Good day, ladies and gentlemen. My name is Philemon Shallie, and I'm pleased to present our work on nanoparticle-based treatments for septic and hemorrhagic shock. This research highlights a promising translational approach that leverages phospholipid nanoparticles to manage two life-threatening conditions, the septic and hemorrhagic shock. Septic shock is a form of distributive shock resulting from severe infection and systemic inflammation. On the other hand, hemorrhagic shock arises from substantial blood loss. In both cases, the patient experiences hypoperfusion, multiple organ dysfunction, and high mortality rates. Some of the major challenges associated with this condition is one, insufficient blood volume and excessive production of nitric oxide. This nitric oxide contributes to vasodilation, which results in hypotension. Our phospholipid nanoparticle is made up of two major components. We have the micelle and the phospholipid. Our formulation has two major components. We have the VBIS, which is used in septic shock, and the VBI1, which we are currently using for a preclinical hemorrhagic shock model. Our formulations have the capacity to take up nitric oxide and to release. The take up is usually during a high concentration, and the release is in an environment of low concentration. Our formulation can also take up oxygen just as hemoglobin does. We also notice a thinning effect with our formulation due to the high viscosity. What this means simply is that it improves microcirculation. We also assess toxicity, and we notice that at a very low concentration of 0.1 to 0.001, there was no toxic effect. We also assess the anti-inflammatory properties by looking at two markers, CXCL10 and CCR7, and in both cases there is significant downregulation of these inflammatory markers. Now, a phase 2 clinical trial. Currently we are in phase 3, but we have the result of phase 2 to present here. Before going into that, let me present the current treatment regimen of sepsis. The first point of call is antibiotics, and when this failed, fluid are given, and when fluid failed, pharmacological agents are administered. And if there's failure at this stage, so many other things are done, such as ECMO, blood filtration, and the rest. And if everything here failed, death ensued. Now, the problem with the current treatment are numerous. Let me look at some of them. Antibiotics, in as much as antibiotics are very good, they actually treat the infection, but they do not take care of the inflammatory stem, nor do they combat the immune dysfunction that is associated with sepsis. How about the fluid resuscitation? That can be described as double-edged sword, because during sepsis the blood vessels actually become leaky, and as a result of that, fluid quickly moves from the vessels into the tissue, causing edema without necessarily improving perfusion. And too much of fluid can actually worsen lung and kidney function. Vasopressors are usually given when the blood pressure is low to increase blood pressure, which of course that is usually achieved, but that does not actually take care of microcirculation, and microcirculation is necessary for oxygen exchange. And of course, so many experiments are ongoing, so many trials. We are still expecting good news, but for now we also have issue with reliable early tests for sepsis. So delay in test actually will lead to severe consequences too. And then finally, cellular dysfunction as a missing target. During sepsis, there is actually a kind of oxygen compromised due to mitochondrial dysfunction. So there is an energy failure when there is mitochondrial dysfunction, and this is not currently being addressed. So we actually believe that VBIS can take care of most of these other steps. So we are proposing that once antibiotics fail, instead of giving fluid or other things, the treatment should go straight to VBIS, and we strongly believe that VBIS will cut out all this stage and improve survival. I'm going to show you some of our data. As you can see, this some of the stuff as the public that we've published our data from the phase 2 clinical trial. This is how VBIS looks like. Now these are the treatment regimen, the volume given. The maximum volume given in a day is 1,500 mils. And then we have some results here for you. The mean arterial pressure, that's MAP. So our target is to make sure that there is an increase in the mean arterial blood pressure for at least 10 millimeters of mercury. Now this column shows the map of patient before VBIS, and so the mean map here, as you can see, is roughly 65, and after receiving VBIS the map jumps up to 77.5, which is actually more than 10 and of course highly significant. And this elevation is achieved in 90 minutes, just 1 hour 30 minutes. We also evaluated the usage of vasopressors before and after VBIS. Before VBIS, the value is roughly 40. Now after VBIS, that's 48 hours after VBIS, the value drops to 15. And you can see that many patients do not need vasopressors after receiving VBIS. So VBIS actually reduces significantly the use of vasopressors. We also look at oxygenation. There is improved oxygenation with VBIS from 2.0 to 2.6 highly significant improvement after 48 hours in oxygenation, which is a very good news. We also checked the serum creatinine. Before VBI1, the level is 2.38. It drops to 1.7 after VBIS, that is in 48 hours, which shows improved kidney function and other organs too. We actually evaluated other parameters, and all the ones on my left in blue column show significant improvement within 48 hours, while the ones on my right in gray column do not show significant difference within 48 hours. Maybe after a long period we might have seen significant improvement, but nevertheless the major parameters are here, such as procalcitonin, lactate, and PCO2, which are markers for actually disease condition or state. Now, this phase of clinical trial, talking about the phase 2A, actually recruited 20 patients, and these are the most severe patients. I mean, the most severe cases of septic shock with an average of 14 SOFA score. Now, SOFA score is a measure of the degree of severity. The lower the SOFA score, the lesser the severity. The higher the severity. Now, for patients that have an average of 14 SOFA score, if that is out of these 20, the anticipated survival is 2 in 20. So 18 of the patients actually were expected to die. But after receiving VBIS, 10 of them walk out of the hospital. I mean, they survived and walked out of the hospital. 4 were withdrawn from the trial by their relatives. And so if they've left them, we would have had 14 survivability, but we ended up with 10, while 6 actually died. Now, be it as it is, instead of 2 over 20, we've actually improved that number to 10 over 20. It would have been 14 over 20 if those 4 were allowed to complete the treatment. So VBIS improves survival and survivability of septic shock patients. In conclusion, VBIS is safe and effective in treating hypovolemia, resulting in an elevation of blood pressure when other fluid and vasopressors fail. VBIS is the first treatment for relative hypovolemia. It is also the first treatment for multiple organ dysfunction. We've seen improvement in cardiovascular, pulmonary, and renal system, as well as in inflammation. VBIS could be effective in other treatment also, such as absolute hypovolemia, in vasoplegia after cardiac surgery, hemorrhagic shock, prolonged surgery, pancreatitis, burns, Ebola, and the rest. Now, let me quickly move to our clinical, that is the preclinical trial with VBI1 in hemorrhagic shock. Now, in this part of the project, we actually use the preclinical model. We use rat precisely. Now, what we did here is that we developed a model we call the model of clinical death. And how do we do that? We bilaterally cannulate the femoral vessel, the femoral artery, and we will draw blood gradually, at least over a period of 2 minutes, rapidly until the animal cease breathing. And at that point, the map is usually less than 10. While on the other hand, we measure the mean arterial blood pressure. And so once we've achieved our endpoint, that is clinical death, the volume withdrawn is either reinfused as shed blood here, or the whole volume is replaced by Ringer's lactate, VBIS or VBI1. So the volume removed in these other 3 groups is completely replaced by this different fluid, while in group 2 here, the shed blood is reinfused. Now that is the setup here. After 4 hours post reanimation, we noticed that those that receive ringer's lactate, of course, hardly go beyond 30 minutes. Most of them actually die before that. It's only one that survived up to 30 minutes, while VBI1 showed higher MAP elevation compared to the other groups, even blood. So we also compare infusing our fluid through the vein and through the artery. Now, intravenous infusion resulted in only 40% reanimation, while 100% reanimation was recorded when the fluid is reinfused. The fluid is infused intraarterially. We went further to extend the experiment 12 hours after reanimation, this time around using only VBI1 and blood, since VBI1 showed a higher level at 4 hours. Now, as you can see, there was no significant difference in MAP between those that receive their own blood and those that receive VBI1. Please note the blood is replaced completely by VBI1 and it's only one bolus. We now harvested the organs after 12 hours to check for reperfusion injury using histology. These are lungs. These are the lungs of the rat that received their own blood compared to those that receive VBIS or sham. As you can see, the damage score is higher in those that receive blood compared to the other groups. We also checked the liver. These are the liver of those that receive their own blood compared to those that receive VBI1 and sham. Here too, the cumulative damage score is higher in those that receive their own blood. We also check the kidneys. So the kidneys of those that receive their own blood compared to VBI1 or sham. The score is still higher in those that receive their own blood, showing that VBI1 actually prevent the organs against reperfusion injury associated with blood transfusion. We now went further to look at the brain this time around. This is the cortex of the brain. These are the layers in sham. These are also the layers in those that receive BBI1. But the layers are completely obliterated in those that receive their own blood, telling us that VBI1 preserved the brain against reperfusion injury. We look at this at different magnification. You can see those that receive their own blood. See, this is VBI1 and this is sham. We look at it in also different part of the brain. This is the cortex, this is the hippocampus. The same result is obtained in the two different brain areas we look at. That's the same thing here. Look at the valculation here, okay, which is not seen in this or in sham. We went further to look at the neuroinflammatory status of the brain in the three groups. Now, we use the macroglia to assess that. Now, let me say this. In a non-inflammatory state, the cell body is usually small and the branching are usually longer and highly ramified, as exemplified by those that receive VBI1. While in inflammatory states, the cell body is large and the processes are short. And that is what is exemplified by those that receive blood. So what this tells us is that VBI1 actually promotes non-inflammatory status. Simply, it has anti-inflammatory properties compared to blood. Oh. We went further to assess those parameters. We actually measure the branch numbers, the branch length, the endpoint in all the parameters. We notice that it is usually longer in VBI1 and sham compared to blood, telling us that sham and VBI1 actually maintains non-inflammatory state compared to those that receive blood. We now also perform the same experiment. This time around, we allow the animal to survive for 30 days. During those 30 days, we measure the body weight. We measure locomotion using actimeter. We also measure cognitive function. The motor function is preserved in those that receive VBI1, just like in sham. There was no significant difference between the groups in terms of locomotion. The same thing was also done when we did the cognition function. This is for YMS, for spatial memory, that tests cognition. We noticed that that is the percentage alternation is higher in the VBI1 and sham. Now, the higher the percentage alternation, the better the memory. Of course, although there is no significant difference, but you can see that VBI1 actually has a tendency towards performing better than those that receive their own blood. So not only does it preserve cognitive function, it also enhances it. All right. And so currently, clinical trial 3 is ongoing, and the result will actually be communicated in due time. In summary, VBI1 nanoparticle platform shows strong potential for transforming the treatment landscape of both septic and hemorrhagic shock. This formulation enhances hemodynamic function, protect against organ injury, and reduce inflammation with no notable safety organs. We will continue to work on this in the future. I want to acknowledge the members of my lab, my PI, Dr. Cobber Sipkins, for his support. And thank you all for your attention. I can take some questions now. Bye.